Hello, everybody. I am Dr. Ibrahim Uman. I'm the current president of the Heart Failure Association of India. And I am very pleased to welcome you all for this physician's course. It's a certification course in collaboration with the Heart Failure Association of the European Society of Cardiology. We have been conducting this year by year, and it's been with very encouraging results. And only one simple thing I would like to discuss, and then I'll hand over to Dr. Hari Krishnan, who is the brain and the brawn behind this program. So the physicians form the root, the foundation, and the structure for management of chronic diseases or non-communicable diseases. India has got nearly 100 million diabetics, another 200 million pre-diabetics, 200 hypertensives, 300 obese. So, and all these leads to heart failure. But we are extremely good in treating coronaries and coronary interventions. But somehow there is some lack in the management of heart failure, as evidenced by the very high mortality as shown in the Random Heart Failure Registry. So when we analyzed, we found that it's the physicians who see stage A, stage B, and many of the stage C heart failures. And this course is tuned to physicians or anybody who treats heart failure for correct diagnosis and management. And we have since the certification course, there is a pre-test for 20 minutes, followed by discussion, and we'll be discussing 3 topics: heart failure in Indian context, pathophysiology of heart failure and heart failure phenotypes, current concepts, and clinical evaluation of heart failure, forgotten yet useful. We have Dr. Amina as the ESC faculty, and I place in record my thanks to the European Society of Cardiology Heart Failure Association and all the participants for this program. So over to Dr. Hari Krishnan to take it forward.
Thank you, Dr. Abraham Uman. Welcome to the this year's physician's course for holistic management of heart failure. As Dr. Abraham Uman has said, the physicians are the key people who treat heart failure, and empowering them by these programs, we believe that it will improve the heart failure care in our country. We know that the mortality of heart failure is at 10 years is 83%, as we have seen in the Random Heart Failure Registry, which is much higher than many common malignancies. So we have seen that the guideline directed therapies use is not optimal, and there is a lot of scope for improvement. That is the idea behind this program, and we are thankful to Heart Failure Association of the European Society of Cardiology, who has joined with us in the form of faculty in participating in all the 6 sessions which we are planning. These sessions are planned every Wednesday from 7 to 9 p.m. online. And each day we will have a faculty from HESC who will be joining for us to discuss the issues. So the program starts with a pre-test. So we will have 25 questions, very basic, simple things which you to understand the basics of the heart failure epidemiology or pathophysiology or the clinical concepts and treatment modalities. And in the next 10 minutes, I will just show the questions and discuss the answers. And after that, we will go to the 3 talks. So that's the plan for today. So we will project you will have the pre-test will come to your mobile or the laptop as a jot form, and you can see that it must have come to your screen. You can just click and access the test. You can Dr. Amina has joined. Dr. Amina, good evening and welcome to the program. So much. Hello. So thank you so much for joining. And we are expecting a good number of participants today. So we are starting with the pre-test. Pre-test will be as a form which will be sent to their mobiles and laptops. They can start answering. And after that, 20 minutes we'll give for the questions to be answered. And And after that 10 minutes, I will be showing the questions and discussing each of them. Then we will be starting with the presentations. So
Yes,
can
sir.
you see myself? Okay.
Yes.
So the first question was, what is the commonest etiology of patients admitted with acute heart failure in India? That is ischemic heart disease. All the Indian registries have shown ischemic heart disease. More than 70% of the patients admitted with heart failure in India is due to ischemic heart disease. Question number 2 is 1 year mortality of heart failure patients admitted with heart failure according to the Indian registries. It is nearly 25%. The Trivandrum registry showed it was 31. The National Heart Failure Registry showed it is 22. So the average is around 25. So the correct answer is 25% 1 year mortality of acute heart failure.
Sir, you have to make it full screen.
So, yeah. Third question is, what percentage of patients who present with heart failure have preserved ejection fraction? More than 50%, that is EF more than 50% in a developing country like India. So the answer is 10 to 20%. In the European registry and the US registries, it is nearly 50%. So that is the difference. Only small percentage of the patients presents with heart failure with preserved ejection fraction in India. Question number 4. A 45-year-old asymptomatic gentleman evaluated prior to hernia surgery was found to have LV systolic dysfunction. He have 45% on echocardiography. He was asymptomatic. He is said to be in which stage of heart failure as per universal definition of heart failure? You know that heart failure is divided into stage A, B, C, and D. A is with the risk factors. B is structural heart disease like ventricular dysfunction. That is what we see in this patient. Stage C is clinical heart failure with symptoms. Stage D is the advanced heart failure. So the answer here is stage B. Fifth question, physical sign with the least specificity to diagnose heart failure in adults is a bilateral pedal edema. It can be due to so many reasons: positive hepatojugular reflex, cardiomegaly, left ventricular third heart sound. All are very specific to diagnosed heart failure in adults. Which of the following medications used for heart failure with reduced ejection fraction do not reduce mortality? The answer is diuretics. Diuretics produce only symptomatic benefit. It has not proven to reduce mortality. That is the answer. So answer is diuretics. It do not reduce mortality. Seventh, one of the following beta blockers are not recommended by societal guidance to treat heart failure with reduced ejection fraction. That is, answer is metoprolol tartrate. That is a short-acting metoprolol is not approved for treatment of heart failure. It is a long-acting preparation. Metoprolol succinate is to be used. Question number 8. A 30-year-old patient comes to emergency department with acute dyspnea. You order NT-proBNP test to rule out heart failure. The value which is diagnostic of acute heart failure as per guidelines is, answer is D, more than 300. So the cutoff is given below. Acute heart failure, BNP is 100 and NT-proBNP is 300. For chronic heart failure, for example, a patient comes to an OPD, then the values are 35 and 125. So these values you should remember. 100 and 300 for acute situations and 35 and 125 for chronic heart failure. Which among the following has the least risk of causing hyponatremia? The answer is furosemide or all others. Thiazides and thiazide-like diuretics causes more hyponatremia than loop diuretics. Question number 10. The ideal time for in-hospital clinic review of a patient who was recently admitted, stabilized, and discharged with acute decompensated heart failure. A patient is admitted with acute decompensated heart failure and discharged. What is the best time to or ideal time to review that patient? The answer is 7 days. That is very, very important. You should review the patient within the first 7 days. Otherwise, the patient can get readmitted with again symptoms. This is because there may be residual congestion in that patient. So you have to identify it and modify the medication. So you have to review the patient at least 7 to 10 days after a discharge. So number 11, you have started RNA in a patient with heart failure. Baseline creatinine was 1.5. It became 2 milligram after 1 week. urine output is normal, serum potassium is normal. What is your plan? Options are withdraw RNA, half the dose of RNA, continue the same dose and monitor closely, change to an AR. The answer is creatinine rise up to 50% is okay, or an absolute value or up to 3 milligram is acceptable. So you continue the same dose and monitor very closely whether there is a further rise in creatinine and the potassium, whether it is rising. So depending upon the further monitoring, you have to closely monitor and continue the same dose of RP. Current role of digoxin in heart failure with reduced ejection fraction, which is true. Answer is it reduces rehospitalization. That is the benefit. Otherwise, it does not reduce mortality. Your patient with heart failure with reduced ejection fraction is on metoprolol extended release 200 milligram once daily, RNA 200 milligram BD, spironolactone 25 milligram OD, and dapagliflozin 10 milligram. So they have all the guideline directed therapy is at full dosage, but still his or her heart rate is 82 beats per minute. What will be your next choice of therapy? So the heart rate is still higher. Our target is less than 70. So we should add evabrad, which will reduce the sinus rate. So the answer is to add evabrad. All among the following are physical findings used to assess fitness for discharge in a patient hospitalized with acute decompensated heart failure, except normal JVP, no dependent edema, no lung crepitations, and attainment of normal BNP levels. So the answer is normal BNP levels will not be attained in most of the patients who are admitted with an acute decompensated heart failure. Some people say 30% decrease in BNP values taken as criteria. So rarely BNP level reach normal levels after treatment for an acute decompensated heart failure. So we cannot use a BNP as a marker to discharge the patient. Other factors like JVP, lung crepitations, etc. can be used. What is a 10-year survival of a post-cardiac transplant in established transplant programs? The answer is 55%. This is from the heart transplant registry of 31,800 patients. 10-year survival was 53%. So the nearly correct answer is 55%. Which is the drug which has shown significant benefit in heart failure with preserved ejection fraction? That is a heart failure with the preserved ejection fraction, EF more than 50%. So the answer is SGLT2 inhibitors, either dapagliflozin or empagliflozin, as trialed in the Emperor Preserved and Deliver trials. A patient with heart failure presents with acute decompensation, blood pressure is less than 70. The inotrope of choice is, so many people have answered, it's norepinephrine. Regarding fluid restriction in heart failure, one of the following is not true. Fluid restriction is recommended in patients with severe congestive symptoms. It is useful in hyponatremia. The answer is routine fluid restriction in mildly symptomatic patients without clinical evidence of congestion is found to reduce mortality. So that statement is incorrect. So routine fluid restriction is not recommended. So only fluid restriction is recommended in patients who are having evidence of congestion in the form of lung crepitations or elevated JVP or edema. The target daily dose of ramipril in patients with heart failure with reduced ejection fraction is 10 milligram. Ramipril, you have to try to attain 10 milligram. Regarding therapy with RNA, which of the following is true? If the patient is on ARB therapy, it should be stopped 48 hours before starting on RNA. That is incorrect. If it is on ACE inhibitor therapy, you have to be stopped for 48 hours, not ARB. BNP should be the preferred biomarker for patients on RNA than NT-proBNP. NT-proBNP should be the preferred marker, as you all know. One advantage of RNA is that it can be safely used in patients with significant hepatic impairment. That also is incorrect because RNA should be used in patients with, should be avoided in patients with hepatic impairment. The only correct answer is target dose of RNA is 200 milligram BD if tolerated. Regarding natriuretic peptides, BNP and NT-proBNP, which is not true, is the lower cutoffs in obese patients. So the answer given was we must use higher cutoffs in obese patients. Actually, lower cutoff in obese patients as the values can be falsely low. Drugs implicated in worsening of heart failure includes ibuprofen. You know that NSAIDs will worsen heart failure. Similarly, pioglitazone. There is a spelling mistake. Sorry for that. Celecoxib, again, an inflammatory drug. And cilnidipine. Cilnidipine is the answer. The current investigation modality, which is considered as the gold standard for assessing chamber volumes and ventricular ejection fraction, is cardiac MRI if available. Most of the times we use echocardiography, but many times cardiac MRI may not be available. But the gold standard is cardiac MRI. A 55-year-old patient with EF, the ejection fraction 35% on metoprolol 200 milligram OD, RNA 200 milligram BD, spironolactone 25 milligram OD, BP 100/70, heart rate 68, left bundle branch block on ECG, has survived a recent cardiac arrest. Still symptomatic. Which among the following is the better management strategy? So this patient has a left bundle branch block on ECG and a recent survived cardiac arrest, and ejection fraction is still 35%. So the patient has a LV dysfunction, wide QRS, and survived a cardiac arrest. So patient needs a CRT and a defibrillator. We will discuss what is CRT and all in the coming classes. So the answer is CRT-D. Last question is, which of the following is an absolute contraindication to beta blocker therapy in heart failure to reduce ejection fraction? The answer is none of the above, because bronchial asthma, well controlled on occasional inhalers, is not a contraindication. Diabetes mellitus is not a contraindication. Fatigue is also not a contraindication. So all three of these situations are not absolute contraindications. You have to give beta blockers because it is a drug which shows a very significant benefit in patients with heart failure. So that is it. So thank you. And we'll go to the next talk. Somebody has suggested to share the answers with explanation in the WhatsApp group. So the answers will be shared in the WhatsApp group. So we will share it. So you can. Abraham, shall I go to the next presentation?
Please do. Please do. It's your talk.
Any comments? We have a very good number of participants this time. So I think.
Yeah, I think it's very good, relevant questions for the physicians. And some doubts among the audience were that how long will these questions will be open for answering?
It will be open. It will be open till the course is over.
End of the course. Or
Yeah.
would it be
2 weeks later also we will keep the course because we have to
Absolutely.
have the post test and the certificate generation. So
Absolutely. So that is wonderful. So I invite Dr. Harikrishnan, who does not require any introduction, as I said, the brain and brawn behind this meeting, so to give his talk.
can you see my screen?
Yes, I can.
So next 15-20 minutes, I will be speaking on heart failure in the Indian context. So the problem of heart failure, as Arnold Katz has said, that heart failure is a mortal illness, more serious than most malignancies. As you see in this chart, you can see that, let's take the pointer. You can see that the heart failure mortality in men and heart failure mortality in women is higher than the mortality of breast cancer, colon cancer, and ovarian cancer. So it is a disease with high mortality. That is a problem of heart failure. So this is the call to action consensus statement which we did during the last CSI 2023, the Platinum Jubilee Conference. So what in that consensus statement where all the major societies across the world, from US, from Europe, from different parts of the world, Latin America participated. We defined heart failure as the third epidemic after diabetes and coronary artery disease. 2.2% of the hospital admissions in low middle income countries is due to heart failure. Therapy is resource intensive and it puts a significant burden on healthcare resources. So we will see what is the data, what are the issues related to heart failure, the potential solutions, and the way forward. So actually, there is no real data on incidence or prevalence in heart failure. So we have to estimate based on extrapolation of data. We take the US prevalence, that is from 2022 in patients more than 20 years. In the general population, it is 2%. So if we extrapolate to 800 million Indian adults, it is around 15 million. That means 1.5 crore people are having heart failure. So it's a huge burden. You can see that in this, you can see this is the projected burden, but the actual burden is much, much higher. So it will be even more than this actually. So why the heart failure is worrying India? That is the question. You can see this is the population of the people having heart failure as the age advances. You can see that as the age advances, the proportion of the percentage of people having heart failure increases many-fold. For example, in more than 60 years, is around 5 to 7% of the whole population is having heart failure. So this is the population percentage of 60 plus in 2011 and what is going to be projected in 2051. You can see that the population 60 plus is going to rise. So naturally, heart failure is going to rise in India. We know that India is a diabetics capital, 8.7% in 2015. It is going to be 110 million in 2040. So 70 to 110 million. So you can see that many of the South Indian states are already red. It is spreading to North India also. So especially in urban areas, both in North and South India, the diabetes is very rampant. In rural areas, even in South India, the diabetes is very highly prevalent. Hypertension, similarly, the fifth NHFS survey 2019-2021, around 1.6 crore people they have screened. Mean age of 41.6, 28% had a hypertension. The important part is only 37% received a diagnosis, 18% of the total reported taking a medication, and 8.5% of the people had a control of blood pressure. You can see that out of 100 people who have hypertension, only less than 10% blood pressure is controlled. So that is the situation. So if you know that uncontrolled hypertension leads to heart failure. So cardiovascular disease, you can see the coronary artery disease prevalence. You can see that India is in the red zone, like Eastern European countries. That means that the prevalence is very high. So we did a study in Trivandrum in 1993. Dr. Ramankutti's group did. The prevalence in the Trivandrum population was 1.4. The same population was studied in 2016. We found that the prevalence has gone up to 3.5. And ischemic heart disease occurs 8 to 10 years younger in Indians. The CREATE registry showed the average age is 57. Kerala SCS showed it is 60. The US data, you can see it is 68. That means that our patients are 10 years younger. What is the data on all diseases like rheumatic heart disease? Is still prevalent in India. You can see that India is still in red, even though some states have very less prevalence of rheumatic heart disease now, but many of the states have still significant number of rheumatic heart disease. Untreated congenital heart disease, 200,000 children born in India, 1/3 of them have critical heart disease. Many of them are late diagnosis, leading on to irreversible pulmonary hypertension. But many of them have simple repairable defects which are not detected on time due to many reasons. Then there are some etiologies which are more common in India, like infectious disease epidemic, like leptospirosis outbreak recently occurred in Kerala also. 4% had heart failure. Dengue fever, which is endemic in some of the areas, 13% of on series had ejection fraction less than 40, those patients who were admitted in ICUs. COVID-19, we know many cases of heart failure we saw. Pulmonary hypertension due to various etiologies, especially due to COPD, due to the biomass fuel use in houses, infective endocarditis, peripartum cardiomyopathy, iron deficiency, which is very common in this region, which can complicate heart failure or worsen heart failure. And rare cardiomyopathies like endomyocardial fibrosis, which is common in some states, and environmental exposures like air pollution, especially indoor air pollution due to biomass fuel use lead on to core pulmonale, and also the PM 2.5 inhalation leading on to increased risk of heart failure. Now we will see for the Indian data on heart failure. This is the data of the Trivandrum registry, the national registry, and the Kerala registry. The National Heart Failure Registry is the largest, 10,800 Indian patients. You can see that, as we have already discussed, majority of the patients, two-thirds of the patients are having reduced ejection fraction. Heart failure with reduced ejection fraction. Preserved ejection fraction is small percentage, 12 to 15%. So two-thirds of the patients are having reduced ejection fraction. What is the commonest etiology? We have already discussed 72% are having ischemic heart disease, followed by dilated cardiomyopathy, and then rheumatic heart disease, and non-rheumatic valvular heart disease like aortic sclerosis. So these three diseases, ischemic heart disease, dilated cardiomyopathy, and rheumatic heart disease, contribute to 95% of the burden of heart failure in India. If you want to concentrate on heart failure, concentrate on these three diseases. So what is the mortality? We have already said in-hospital mortality is high, 7 to 8.5%. In high-income countries, Europe and USA, it is 4 to 5.5. So significantly higher, almost double. Long-term mortality, 1-year mortality is 30%. 3-year mortality is 45. 5-year mortality is 59. And 10-year mortality now we have unpublished, but it is more than 80%. And this is the socio-demographic profile of our patients. Younger patients by 10 years, they present late. For example, most of the patients are having ischemic heart disease. The door-to-balloon time is high in India. Untreated congenital heart disease, we have already discussed. Our patients are less likely to get evidence-based therapy due to many reasons, including accessibility, availability, and affordability. This leads to worse outcomes, higher in-hospital and shorter mortality, out-of-pocket health expenditure, accessibility issues, which we will discuss subsequently. So heart failure in India, the burden is likely to be high, more in the younger population, mortality is high, expected to rise if the current trends can. If you don't do anything, it is going to rise because of the rise in the prevalence of risk factors and persistence of old age diseases. This is what we call the double burden of heart failure. So, but the good thing is that we have now a very effective drugs which can reduce the mortality of heart failure. For example, if you give these 4 pillars of heart failure with the reduced ejection fraction, we can give 5.5 more years of life to a patient aged 55 who is presenting with heart failure with reduced ejection fraction. So 5.5 years of more life to the patient by giving these drugs. So that is the importance of treating such patients, and that is the importance of doing such programs to drive the message that the guideline directed therapy works, it improves the outcomes. So these are the major drug groups: beta blocker, ACE inhibitor, or RB or ARB or RB, mineralocorticoid receptor antagonists like spironolactone or replacement, and SGLT2 inhibitors. Then other drugs like hydralazine nitrate, ivabradine. Then we have vericiguat for recurrent hospital admissions. Then you have to control the risk factors like CKD, IV iron deficiency, has to be IV iron for iron deficiency correction, management of valvular heart disease, atrial fibrillation, sleep apnea have to be managed, and vaccination for influenza and pneumococcal has to be given, management of depression. These are the other comorbidities which we have to consider. So when we consider about the guideline directed therapy, we have to consider 3 aspects. One is we have to give all the 4 drugs, group of drugs. For example, you have to give ARNI, beta blocker, mineralocorticoid receptor antagonist, and SGLT2. And we have to give them at the target doses. In the questions also, we discuss the target doses. I will discuss it. We will discuss it in the subsequent sessions. For example, if you take metoprolol, it is 200 milligram long-acting metoprolol orally. ARNI, it is 200 milligram BD. Spironolactone, it is 25 milligram. Dapagliflozin or empagliflozin, it is 10 milligram. So these are the target doses. So we have to reach the target doses. Some patients we know that we may not be able to go to the target doses. Then we have to try to the maximum tolerated doses. That is where we try our best. BP may be low, heart rate may be low, renal function is deteriorating. Then we have to stop at some point. So that is the point where what we call as a maximum tolerated doses. And time to initiation and optimization of dosing is usually very slow. We should do it in 3 months time. 3 month time. So the titration to this 200 milligram of metoprolol, for example, you have to do it in 3 months. Then you will give the maximum benefit. So are we doing that? We are not giving the therapy. You can see that these are the Indian registries. The GDMT prescription is 25 to 47%. And giving the GDMT, you are seeing a very significant benefit in Indian patients also. So we have to give the drugs to these patients. And titrating, are we titrating to the target doses? We may be giving at small doses, for example, 25 milligram of metoprolol. That will not give the maximum benefit. So actually what we are seeing is even in the Western world, that titrating to the maximum tolerated dose is only in around 10 to 25 prescriptions. So here we can improve our the therapy to our patients. What are the factors associated with the non-use or sub-target dosing? Maybe lower body mass index, worsening renal function, hyperkalemia, lower blood pressure and heart rate. This may be the reasons. And non-pharmacological management of heart failure like rehab, treatment of depression, tobacco cessation programs, dietary modifications, advice of a dietary specialist are all not very commonly practiced in many of the hospitals. So issues related to heart failure care in India, I have divided into accessibility issues, availability issues, and affordability issues. Accessibility, we know that India has uneven and limited access to healthcare. People living in remote villages, highlands, islands, limited access, overloaded public healthcare system. We don't have an emergency medical service ambulance, not universally available. It's available in many places, but not universally available. And facilities for periodic blood test, follow-up, and cost are also very important. Availability, we know that heart failure requires intensive specialist care, at least in the acute phase. Dedicated heart failure units are only few and in very major cities. Centers which can manage the sick patients are available, but it is concentrated in the cities like when they need hemofiltration, when they need inotropic support. But expertise is available and we can even build it. Affordability is also very important. You can see that this is the study which we have done showing the prices of drugs in Janaushadhi, that is the generic drug outlet by the government, and a branded drug. You can see that the cost varies from 2,300 to 4,500. It varies from if you buy from the Janaushadhi or from the branded, there is a significant difference in the prices. And device usage, for example, if you want to see the usage of devices like defibrillator and CRT, this is the data from the different Indian registries, is less than 2%. But you see in the Netherlands in 2020, around 42% of the patients had some form of device. Because we know that heart failure is a very high risk, prone for sudden cardiac death. So the device usage is very low, possibly because of the affordability. We know that it will cost around ICD around 4 to CRT to 4 to 7 to 8 lakhs. So the affordability may be a major issue. So what can be done to improve the guideline directed therapy? Heart failure clinics can be established. So what is a heart failure clinic? It's an organized setup for a regular and systematic follow-up and management of patients with heart failure aimed at improving their outcomes and quality of life. So it is a simple system. You don't require any special infrastructure. You convert one of your days to a heart failure clinic and give a systematic follow-up to these patients. That is what is heart failure clinic, and Heart Failure Association of India is starting heart failure clinics in a big way. So we are going to, I think many of you are part of the program. We are starting pilot clinics 50, and we are aiming to increase it in the future. So the goals are to reduce mortality and morbidity, to reduce readmissions by educating the patients, providing a helping hand when they decompensate, and guiding the patient towards better possible medical device and surgical therapy. So who should manage heart failure clinic in the Indian settings? Or possibly a trained heart failure nurse is the most suited in the Indian setting. Even though the nurse practitioner concept is not in India, where the nurse can prescribe drugs. Here only the physician can prescribe drugs. But the trained heart failure nurse can get the advice of the cardiologist and physician and help in titrating the drug dosages. They can supervise the exercise rehab and also give counseling regarding depression, anxiety, and also give dietary advices. And nurse-led heart failure clinics and telemonitoring programs are found to be cost-effective and found to be better. Physician education programs like this, we know that clinical inertia, when we start a drug, we think that the blood pressure may go down, patient feel bad. We start ARNI, the blood pressure may come down, the creatinine may go up slightly higher, or the potassium may go up slightly higher. We stop the drug. So that type of clinical inertia should be avoided. That is how we do these programs to get rid of this clinical inertia. So that is why we have conducted the programs for the last, I think Dr. Abraham said, this is the 6th program which we are doing. Last year also we did the support of Heart Failure Society of America. Now we are doing this with the Heart Failure Society Association of the European Society of Cardiology. Quality improvement initiatives can be done like heart failure fellowship, short courses for heart failure, courses for heart failure nurses, which we Heart Failure Association do regularly. The advices for starting heart failure clinics, how to establish, how to sustain. And accessibility issues, establishing more centers for heart failure clinics. You can start monthly heart failure clinics in all district headquarters. Centers of excellence, how to refer for specialized care, for example, transplant. Referral system should be properly implemented. Point of care devices, for example, if you want to test electrolytes, test BNP, you can have point of care devices where you need not require a high-end lab setup. Technology innovations can be used like mobile phone-based follow, periodic reminders to patient, tablet-based interactive systems for primary healthcare workers and physicians. That is being tried in many centers. Telemedicine linked to primary healthcare centers, where a specialist sitting in a district hospital or a medical college can give guidance to physicians in primary care centers. Affordability issues can be tackled by control of essential drug prices, generic drugs, subsidy or financial assistance for prolonged drug therapy. Now we give financial assistance for procedures like angioplasty, but subsequent drug therapy we are not providing assistance. So that also need to be given. Medical insurance, we now have the Prime Minister's health program. So that also is helpful in improving the affordability issues. And heart failure polypill, that is one concept. We know that heart failure, there are 4 or 5 drugs to be taken. So it is difficult to take all the 4 or 5 drugs. That is how the polypill concept came. So 4 classes of guideline-directed medical therapy are put in a single pill, and most of these drugs are generic drugs. So the cost also will be less. So the affordability and the adherence issues for taking the difficult to take 4 or 5 drugs, that also will be less. So that is a polypill strategy. There are certain trials which are started in the US, and also Indian studies also on the card. The same drug has been tried in Sri Lanka with the safety is established. The study is also supported by Washington University. Study is going to come in India. So to conclude, ladies and gentlemen, issues in heart failure care in India, we know that it's a rising burden. Our patients are younger by 10 years, higher morbidity and mortality. Our health systems are burdened, especially the primary care systems. Accessibility and availability issues are there. Out-of-pocket health expenditure, and low guideline-directed therapy. Potential solutions, formulate methods suiting local needs and available resources. Development of local guidelines and care pathways. Task shifting from to physicians to healthcare workers and heart failure nurses. Referral pathways, centers of excellence. Strengthening primary care, heart failure clinics, and even checklist. Simple checklist at admission. Simple checklist at discharge may help the patients. Generics and polypill, all this will lead to improvement of care in heart failure. And quality improvement initiatives like this, the physician education programs. So thank you. And we can have some discussion now.
Thank you, Dr. Hari. My wonderful talk. So, can you hazard a guess if somebody uses all 4 drugs, at least in 50% of the dosage in India, how much would the mortality come down? I know it's just a guesswork, but because these registries were 3 drugs, mostly ARNI usage was very low. Even National Heart Failure Registry, I think it was around 5%, up not very high. So, like when you have these 4 drugs now, like the cost of therapy has come down dramatically. Even you have, as you said, Jan Aushadhi, and even the so-called Jan branded drugs, the cost has come down. So if somebody gets these 4 drugs, at least 50% of the dose, how much would the mortality take? Because 10-year mortality is 83%. Would it come to less than 50%?
Yeah, I think it will significantly come down. The problem what we have seen is many of our patients, we are not able to go beyond 50% of all the 4 drugs, many of the 4 patients. So at least if we give 50% of the target doses of these 4 drugs, definitely, I think dapagliflozin, empagliflozin, we can give 10 milligrams. Spironolactone, we can give. The problem is with the beta blocker and the RNA. So many of we can come down on that even up to 50%, then it will produce significant mortality benefit. So my advice is to give the drugs whatever dose possible you give and try to reach even at least up to 50%. It is said that even if you reach 50 to 99% of the target doses, you will derive almost the same benefit as you reach the target doses. So our aim is to reach at least 50%. And many people have asked for the slides. Slide we will share it in the group. And polypill is only a conceptual stage now, and because it has to be given a single day, RNA is not there in some of the polypills. So it is some contains ARB. It is a concept which is evolving. It is not yet marketed. So it will take time. But the basic idea is that to give all the 4 pillars, if you are not able to give RNA, try to give at least an ACE inhibitor or ARB if possible. That is the message. These questions will be answered next time. So please, yeah.
Yeah, that's for the audience. The discussion in the next week session will be answering the questions and summarizing what had happened in this session. So, Dr. Amina,
please
any
post your
questions, any
questions.
comments? Yeah.
Yeah, please post your questions. I am seeing some interesting questions. So, okay, beer biryani, beef parota, beverages. Okay, so many interesting questions are being posted. Anyway, we'll be sending answers to those questions. So we'll move to the next session by Dr. Amina. Dr. Amina, please, your talk is already recorded. Do you want to play it or you want to come live?
Hello once again. I would just like to welcome you all here and thank you very much for your invitation. Yes, my talk is pre-recorded, so I'm here and I will be very much happy to discuss after the pre-recording. Yeah, it's true.
Thank you once again, ESC Heart Failure Association, for this wonderful support given to Heart Failure Association of India. So thank you, and over to Dr. Amina.
This is a great honor for us as well, because this is something that we're really much delighted to share our knowledge, our thoughts and all efforts that we're doing the joining and a joint session. So we are very much happy to be part of your course. Thank you.
Yeah. Thank you so
that's
much.
my great privilege to be part of the physician course on heart failure, and I would like to talk with you about pathophysiology of a heart failure and heart failure phenotypes. What are the current concepts? My name is Amina Rakisheva and I'm from Almaty, from Kazakhstan. So the oldest case of a heart failure was actually revealed, and it was a mummy that was opened in Egypt that actually belonged to the 18th century dynasty, and what it was show that examination of the lungs show that this mummy, Nibiri, had what the research team calls heart failure cells and evidence of edema or fluid collected in the lungs area. What does this case show? This case shows that already, the conception of congestion that actually also relevant nowadays. If we are saying about a heart failure, we also have to say that the heart failure, or maybe a chronic and persistent heart impairment, actually has non-specific symptoms such as a breathlessness and fatigue. But what is important, it has also a high impact on our quality of life and mortality. The global burden of a heart failure, it's around 63 million across the globe. And what we have to say that it is important to know that as we have good treatments, especially for heart failure with reduced ejection fraction, and we have also improving a good treatment for heart failure with preserved ejection fractions. Therefore, it is important to not only thoroughly detect, also to make the diagnosis of a heart failure, so we could specifically treat these patients for improving the outcomes of them. In the United States, the data that were extracted from 1979 to 2006 showed that the rising prevalence of a heart failure, and actually this trend showed that the increased prevalence of a hospital discharge for heart failure in both gender, male and female. What is interesting that the female has higher prevalence compared to men. Maybe that is due to their presentations in the older age, or maybe due to the prevalence of a heart failure with preserved ejection fractions. Nevertheless, the slide showed and underscores the importance of early detection to improve the outcome of a patient with a heart failure, and also to reduce their heart failure hospitalizations and reduce the cost of our healthcare system. One more thing that actually showed the importance of a heart failure, of early treatment and early detection, and maybe it should be as urgent as we're treating the cancer, because here in this diagram we can see that their survival rate in patients with a heart failure, it's worse, it's poorer compared to prostate cancer or breast cancer in women. Therefore, we really need a multidisciplinary care as early as we can to improve the outcome for our patients and to improve and increase the survival rate of them. Well, we do know about risk factors that actually risk factors such as hypertension and diabetes and CKD. Both of them, their hypertension and diabetes, lead to left ventricular hypertrophy and injury. So both of them can activate RAS system, and the further progression is lead to development of diastolic or systolic dysfunction. And actually, furthermore, it goes to their heart failure itself. What is important to know? The subclinical left ventricular dysfunction, a symptomatic left ventricular dysfunction, it's our window that actually gives us opportunity to prevent deterioration and prevent further progression of a heart failure in our patients. We also have to know that if we are saying about myocardial changes in left ventricular remodeling, we have to remember about a key alterations in myocardial in these patients. So we have to keep in mind about alterations in myocyte biology, about myocardial changes, and also about alteration in left ventricular chamber geometry, which actually we have to talk about increased size, increased sphericity, wall thinning, mitral valve incompetence. And as we already said about RAS activation, it's important just for you for your information that the long-term harmful effect of RASi activation is going to the water and salt retention and also for the adverse ventricular remodeling. But as long as it will be the water and salt retention, we have to understand that the worsening of a heart failure symptoms and progression of a heart failure will also become more clearly in our patients and also increase the mortality. Therefore, this slide showed us that we do need to inhibit the RASi in our patients. And let's not talk now about therapy, but it's one pivotal thing that we have to keep in mind when we're talking about RASi activation. We really need inhibition of the RASi. Another neurohormonal system that actually normally it's protective function, but when it is heart failure and when is the baroreceptor dysfunction appear, then we have to understand that there will be activation of sympathetic nervous system of RASi system and also of vasopressin secretion, which actually will lead to fibrosis, to increase of aldosterone secretion, to sodium reabsorption and water retention. So once again, it showed us as another important system that should be kept in mind of what we have to treat pathogenically treat our patients. Therefore, this was a landmark study that was published in June 1987 that actually showed exactly that the inhibition of RASi system by enalapril will significantly reduce the cumulative probability of death in patients of enalapril arm compared to placebo arm, and that was the first trial that showed the beneficial result in patients for RASi inhibition. Well, another study that actually fundamental study, a real study that was published later on in 1999 also showed us that patients that are treated with spironolactone will have better outcomes compared to placebo. What is interesting to note that actually this study showed that their spironolactone was given up to diuretics and ACE inhibitors, less number of beta blockers, but still we have diuretics and ACE inhibitors that actually also can show us one more thing that about evolving of a heart failure treatment from enalapril, from the consensus study to the rails. Well, one more thing that showed us that neurohormonal activation actually in patients with a heart failure, it's also plays not only showing not only importance in a pathogenetic role, but also important a prognostic marker. So if we can see here norepinephrine, renin, NF, and vasopressin, they showed the increase even in asymptomatic patients, and of course in patients with who are symptomatic. What does it mean? So it's not only prognostic outcome, but it also shown that us about early detection that actually can prevent and can improve the outcome of patients with a heart failure. And again, this the data about norepinephrine as a prognostic marker in patients with a chronic congestive heart failure was one more proved in this very, very nice study that was published by Jay Cohn. And what does a study in New England Journal in 1984, but what does this study show us? That predicted survival curves based on initial measure of norepinephrine level is important. So the patients with their norepinephrine level, initial level of norepinephrine more than 1,000 will have a very bad outcome compared to patients with a norepinephrine level around 200. It also will showing us that the rapid deterioration and rapid worse outcome in patients with very high level of norepinephrine. What we also showed here about sympathetic
Is there a problem with the sound, Vinay?
apoptosis and fibrosis, and also to increase number of arrhythmias and of course impaired diastolic and systolic function. If we are saying about kidney, the kidney there will be activation of RASi system, and also about water and salt, vascular resistance increased. And as for the vasculature, then we have to understand that it will be hypertrophy and also vasoconstriction. Well, just to remind you about universal definition and classification of a heart failure, that was a very important and nice universal definition, the first that was published with by the Heart Failure Society of America, together with Heart Failure Associations and Japanese Heart Failure and other cardiac of Australia, New Zealand, and other societies. What is important? First, in this universal definition, we were discussed about clinical trajectory and terminologies in a heart failure. So we have a new onset or de novo heart failure, worsening heart failure, improving heart failure, also persistent heart failure. What is important that we don't need to use a stable heart failure. Instead, we have to. It's better for us to use a persistent heart failure. And of course, about heart failure in remission, because we can't say recovered heart failure. In that matter, we have to use a heart failure in remission. And this exactly, heart failure in remission, is very important because of a Tradichev studies that showed us there is no recovered heart failure, only in remission. Well, and of course, according to the universal classification of a heart failure, there are different phenotypes according to left ventricular ejection fraction. So we are talking about reduced ejection fraction, we're about mildly reduced with preserved, which is more or equal 50, or heart failure with improved ejection fraction. That is actually the baseline ejection was below 40 or equal 40, and increased for 10 points from the baseline ejection fraction, and a second measurement of ejection fraction more than 40%. Well, let's talk about heart failure with preserved ejection fraction now. And we do remember all the studies that actually showed that there is no benefit result compared to from their active arm compared to placebo arm, with exception of sacubitril valsartan that actually missed his significance, but showed a better result in women compared to men. But overall, there is no difference in both arms, compare placebo and placebo and treatment arm. What does it mean? So if we are talking about heart failure and preserved ejection fraction, then we need to remember that heart failure and preserved ejection fraction, it's will appear as a concentric hypertrophy together with diastolic dysfunction. And if we are saying about phenotype profiling patterns, then we have it's vary from normal heart to concentric remodeling, concentric hypertrophy, and eccentric hypertrophy. And if we are saying about what are the comorbidities that actually lead to or progress to heart failure with preserved ejection fraction, of course, it's a hypertension, it's diabetes mellitus, it's a coronary artery disease, it's obesity, COPD. And as for key features, we have to keep in mind about diastolic dysfunction, about pulmonary hypertension, abnormal systolic function, impaired oxygen utilization, and impaired left ventricle systolic and diastolic reserved, and of course, chronotropic incompetence. So, we have several questions that we have to address about other common about. Is the mechanism is common or it's different? That's the first. And also, does one size fits all? And what about target comorbidities? So let's talk about that. Two landmark studies for the SGLT2 for dapagliflozin together with empagliflozin that showed that patients with mildly reduced or preserved ejection fractions, as it was shown in DELIVER study with the dapagliflozin, showed the beneficial result in dapagliflozin arm compared to placebo, with reduction of 18% in dapagliflozin arm compared to placebo in primary outcome, and again 21% risk reduction in empagliflozin arm compared to placebo in a primary outcome for patients with preserved ejection fraction. one more important pillar is finerenone, and here you can see two different studies, the Fidelio-DKD and Figure-DKD. Both of the studies included patients with type 2 diabetes and chronic kidney disease, and well, of course, there were exclusion criteria, and there were a patient with reduced ejection fractions were excluded from this study. As for primary outcome, then in Fidelio-DKD, the primary outcome was a composite of kidney failure and sustained decrease of at least 40% in the eGFR to 4 weeks or renal death. And if we're saying about Figure-DKD, then we have to just to keep in mind about primary outcome that here it was composite of cardiovascular death, myocardial infarction, stroke, and heart failure hospitalization. What do these studies show us? The beneficial result in both studies for patients with type 2 diabetes mellitus together with CKD. And we can see also that hyperkalemia-related discontinuation was slightly higher in finerenone arm compared to placebo in both study, but it was not so significant. Well, there was a pooled data analysis of both of this study that actually had a bit different protocol. I mean, when they made a pooled data analysis, but the outcomes for this analysis was if we are saying, were two different outcomes, cardiovascular outcomes and renal outcomes. If we are saying about cardiovascular outcomes, we have to say about time to cardiovascular death, non-fatal MI, non-fatal stroke, or heart failure hospitalizations. And if we are saying about kidney outcome, then it's a kidney composite outcome, time to kidney failure, sustained decrease in eGFR, or renal death. So there is a fewer hyperkalemia-related discontinuations occurred in both arms, but what is important, that finerenone on top of standard of care reduced the risk of clinically meaningful cardiovascular and kidney outcomes in patients with type 2 diabetes over a broad spectrum of chronic kidney disease, and it was actually a safe enough for patients. So one common mechanism or many different targets. What are we saying? What should we keep in mind? So if we are saying about a non-steroidal MRA, so and this study was presented last year in during AEC, and it showed that in this study, patients were included with ejection fractions over 40 and with a New York Heart Association class 2 to 4 and increased NT-proBNP level. So we are talking about patients with a heart failure and preserved mildly reduced or preserved ejection fractions. And the primary outcome was a composite of adjudicated cardiovascular deaths or total heart failure events, well, heart failure hospitalizations or urgent heart failure visit. Again, finerenone showed the beneficial result compared to placebo for the primary outcomes and also for, if we're saying about secondary outcomes. And again, if we're saying about hyperkalemia-related discontinuation, it was higher in finerenone arm compared to placebo, but not so. So we're saying about a safety profile of finerenone in patients with a heart failure and preserved and mildly reduced ejection fraction. So I would like to stop here in a Spirit HFpEF study. It's a registry that actually showed us that the beneficial outcome of patients with who will receive non-steroidal MRA compared to placebo. What is important here? So if we are saying about overreaction of a mineralocorticoid receptor. So it's our targeting system impact with a non-steroidal mineralocorticoid receptor antagonist. So both aldosterone and cortisol go into progression of mineralocorticoid receptor overactivation. And we can see here about inflammation, about oxidative stress, stiffening, fibrosis, and cardiac remodeling. What is interesting to see see when we're comparing steroidal and non-steroidal finerenone or spironolactone, then we have to see that actually finerenone has more selectivity compared to spironolactone, and also it has increased potency for mineral MR overactivation, and also it shows their inverse agonist compared to partial, as it was for spironolactone, and also the different structure in the bulky structure and for flat structure for spironolactone. So we can say that actually finerenone, the lessons that we learned from the animal models, finerenone versus eplerenone has less macrophage invasion, will reduce cardiac fibrosis, and will increase longitudinal strain. Well, again, one more thing, if we are saying about kidney, reduce renal fibrosis and reduce renal dysfunction. Improve endothelial dysfunction and oxidative stress. And what is important to know about heart, so finerenone compared to eplerenone will reduce cardiac remodeling, proteinuria, and also reduce the NT-proBNP level. Well, I very much like this Swedish registry that showed us 5 different clusters, and exactly according to these different clinical phenotypes that were actually classified in 5 clusters, their outcomes in the cardiovascular deaths or heart failure hospitalizations were absolutely different. So the worst outcomes were for the cluster 3, who were oldest with many comorbidities, and also with hypertensive patients. And the cluster number 5 was, again, we are saying about older age with ischemic heart disease, together with many comorbidities such as diabetes, hypertension, impaired renal function, and with the use of diuretics. Another important thing that again showed us about different clinical phenotypes that actually probably is showing us these different phenotypes, showing us the targeting for our treatment. So this study showed us that there are different subgroups, clusters, let's say clusters from the eye-preserved analysis. So the subgroup C and subgroup F had the worst outcomes compared to others. And who are they in this subgroup? So the median age was about around 70 for subgroup C, had higher rate of obesity, diabetes. So we're saying about multimorbidity and anemia with the worst renal function than other subgroups. Subgroup F, predominantly women, that actually more prevalent for HFpEF compared to men of advanced age. And here we're saying about a median age of 82 with low BMI and high rate of atrial fibrillation, valvular disease, renal dysfunction, and again, an anemia. So we're saying that there are some different target. And actually, subgroup C showed the beneficial result when the irbesartan was used in this subgroup compared to placebo. So does it mean that there are different answer in a different clinical phenotypes for our treatment? So probably we also can use the RASi inhibitors in a different phenotypes in patients such as their subgroup C for better outcome in patients with preserved ejection fraction. Well, this is a very interesting and important study that actually the data were from identified in a TopCut study. We can see that there are 3 different clinical phenotypes in a heart failure with preserved ejection fraction, and with their better outcome survival, with a higher survival probability for the phenotype number 1, with a normal geometry of a left ventricle, with a low arterial stiffness, low level of natriuretic peptides, marker of CAPD, not genuine HFpEF, low event rate, and and preferentially enrolled in Russia or Georgia. And their worst outcome was for phenogroup number 3, who are more obese or with a diabetes, with inflammations, with abnormal metabolism, liver and renal injury or maybe dysfunction, with a high renin level, highest risk of primary endpoint. And this group of patients actually preferentially responded for spironolactone. So we are really saying about a different answer for a different clinical phenotype group in a heart failure with preserved ejection fraction. Therefore, we made together with my colleagues from Heart Failure Association, we proposed a statement about patient phenotype profiling in a heart failure with preserved ejection fractions that should be guided to therapeutic decision making. And we're showing here that patients can be in a different phenotype with a different answer, with different ejections and different comorbidities. We do remember that obesity plays also a very important role in a heart failure with preserved ejection fraction. We remember that the majority of patients with worse outcomes were obese and with type 2 diabetes. So the SELECT trial showed us that this all-cause mortality by history of heart failure and subtype at enrollment, there is no difference in answer for the semaglutide in both arms, if there is heart failure or no heart failure. So we're saying that the interaction value was 0.9, and it's quite there is no interactions between two groups. And as for heart failure subtype, so there is a trend, but there is no interaction in both arms with reduced ejection fraction and preserved ejection fraction, but it was a better outcome and significance in heart failure with reduced ejection fractions compared to HFpEF. Another study with tirzepatide that included patients with a heart failure and preserved ejection fractions and age over 40 with New York Heart Association 2 to 4 and increased BMI level, showed us that the cumulative incidence rate was lower, significantly lower, 38% compared to placebo. And actually that the cumulative incidence was for the deaths from cardiovascular causes or worsening heart failure event, and also assessed in a time to first event analysis among our patients included in this study. Well, as for iron deficiency, again, iron deficiency plays also a very important role in a heart failure. Their data from the FERRET HFpEF trial showed us the improvement of 6-minute walk test in patients who received ferric carboxymaltose compared to placebo, and it was significant improvement over quality of life. So we are saying that their prescription over IV iron can improve the quality of life in patients with HFpEF. And of course, we have to keep in mind about hypertension, because hypertension and the data taken from the reverse left ventricle hypertrophy study that included patients with adult with essential hypertension and who really had a hypertrophied left ventricle. So it showed us that there was a reduction in LV mass and also decrease in left atrium size in sacubitril valsartan group compared to valsartan. So it's very, very much important to target treatment, not also to our comorbidities. And in 2023 focus update of the heart failure guidelines, we emphasized their importance. First, we emphasized about treatments that actually one fits for all. We are saying about diuretics for fluid retention. We are saying about dapagliflozin and empagliflozin. And we are saying that we do need to treat etiology and cardiovascular and non-cardiovascular comorbidities. So that is what important in heart failure with preserved ejection fraction nowadays. As for patient phenotype profiling, we have to look for the patients and what comorbidity, what a clinical phenotype of these patients, and accordingly, we can also give an opportunity, give a very specific treatment for patients. So it will be personalized treatment for patients with preserved ejection fractions. So thank you very much for your attention, and that's all.
Thank you, Dr. Amina, for that wonderful presentation. So it is open for discussion. Abraham, any comments?
Wonderful talk. Can you highlight once again about gender differences in the pathophysiology? That is, I think, something close to your heart also. And a lot of discussion in India about the females have being a special subgroup or pathophysiologically different from males in heart failure.
So if we are saying about male and female, there is, we have a different prevalence in HFrEF and HFpEF. And actually also there was a very different number of trials that showed that the most prevalence over HFrEF is belong to males. It's because of our increased level of MI about our CAD and so on. So we do need some common risk factors, and also we do have some specific risk factors. So for male, it's increased number of CAD, MI, and of course then it's a more prevalent HFrEF. As for female, then we're saying about HFpEF, and also we're saying about aged patients, we're saying about atrial fibrillation, diabetes, obesity. So this is important. What is also important that there is, if we are trying to diagnose a heart failure with preserved ejection fractions, there are different there are a number of difference between a diagnosis in men and compared to women, because there is a more E to E prime, increased level in women compared to men. There are echo data. There are also NT-proBNP level will be lower in women compared to men. It's because of estrogen insufficiency and other different kind of factors. As for treatment, we also have the data from the sacubitril/valsartan from Paragon-HF study that showed us the benefit result of sacubitril/valsartan in females compared to males. So this is really tend to discuss about that we need to emphasize the difference even in the guidelines between man and female. So it's probably that will be someday highlighted, and maybe we will have a consensus statement for a different type of a diagnosis criteria for heart failure with preserved or even with reduced ejection fraction for women. And also there are also evidence for different kind of a criteria for ICD and CRT implantation. So for CRT implantation, so for females, because we do have smaller heart, we pump faster, and this is important. As for different kind of phenotypes, so as I already said, that's also belong to relaxation and to systolic and diastolic dysfunction. So if we are saying about a heart failure with reduced ejection fraction, we're saying about falling heart. And if we are saying about heart failure with preserved ejection fractions, then we're saying about more hypertrophied left ventricle together with diastolic dysfunction. So this is the main and more obvious difference between these two different phenotypes, but also the comorbidities that play a crucial role in HFpEF, because we are saying that there was even if we are saying about worse outcomes, maybe less for cardiovascular outcome, but more for non-cardiovascular outcome and impact in patients with heart failure with preserved ejection fraction.
Shall we move to the next talk, as already it is 8:40. So over to Dr. Venugopal for the talk on clinical evaluation, heart failure still relevant.
Thank you, Hari. Is my slides visible?
Yeah, it's visible. So, thank you, Dr. Amina, for that presentation and joining for the discussion. Thank you so much. Venu sir, please.
Thank you.
Thank you. It is a wonderful talk by Dr. Amina regarding the heart failure and the phenotypes and pathophysiology. Now we are going back to some basic clinical aspects in heart failure. Clinical evaluation in heart failure, forgotten yet useful. I would just like to thank Dr. Hari and Dr. Abraham Uman for having given me this opportunity to talk on this simple topic. The definition of heart failure is that it's a complex clinical syndrome resulting in structural impairment of ventricular filling or rejection of blood. With increasing treatment of coronary artery disease, valvular heart disease, and cardiomyopathies, the proportion of heart failure is also increasing. The early diagnosis of heart failure is essential for initiating guideline-based treatment and improving the prognosis. Though we have a lot of investigations which are now become very important in the management, a proper history and clinical examination are actually fundamental to the diagnosis and management of patients with heart failure. The other important aspect of clinical examination is that it allows a non-invasive assessment of patient's hemodynamic status, whether there is congestion or hyperperfusion, and this will also target your therapy to improvement of patient's symptoms. Now, if you look at the stages of heart failure, this is a question which Dr. Hari had asked you in the pre-test. There are different stages of heart failure. Stage A, at risk for heart failure. Stage B, pre-heart failure. Stage C, symptomatic heart failure. And stage D, advanced heart failure. In stage, the importance of identifying these stages is that patients with hypertension, diabetes, obesity, exposure to cardiotoxic drugs, genetic cardiomyopathies, or family history of cardiomyopathies are patients at high risk for heart failure, but they do not have any symptoms or signs. So these are the patients whom we have to follow very carefully to prevent the onset of heart failure. For example, patients with hypertension, coronary artery disease, and diabetes, their risk factors should be properly looked after. The hypertension should be controlled, diabetes should be controlled, and also periodic evaluation of patients with ischemic heart disease where they are developing LV dysfunction. All these are extremely important in stage A. In stage B, as Dr. Hari's patient, asymptomatic left ventricular dysfunction. Again, we have, even though the patient may not have any symptoms, we have to find out whether these patients are having subclinical heart failure, especially with the use of natriuretic peptide levels, cardiac troponins. Stage C, symptomatic heart failure, patients with current or previous symptoms of signs of heart failure. And stage D is advanced heart failure, where their symptoms interfere with daily life and recurrent hospitalization, despite attempts to optimize guideline modified treatment. Now, the trajectory of class C heart failure has also been said earlier by Dr. Amina. The new onset of de novo heart failure can have resolution of symptoms, they can have persistent heart failure, or they can have worsening of symptoms. And as she said, heart failure can be in remission. There is no situation where it is going to be a complete cure, but heart failure in remission is a term that we now use for patients who have improvement in symptoms with treatment. Even though, as Dr. Harikrishnan said in the etiology of heart failure, the major cause of heart failure is actually ischemic heart disease, one has to remember the other potential non-ischemic cause of heart failure. Most important are chemotherapy and cardiotoxic medications, rheumatologic or autoimmune, endocrine or metabolic, thyroid, acromegaly, pheochromocytoma, diabetes, and obesity, familial cardiomyopathy, inherited or genetic heart disease, heart rhythm-related tachycardiomyopathies, hypertension, infiltrated cardiac disease, myocarditis, infectious toxic immunological or hypersensitivity, peripartum cardiomyopathy, stress cardiomyopathy, and substance abuse, especially alcohol, cocaine, and methamphetamine. The special points in history of heart failure, which are often overlooked, are the history regarding cardio-oncology drugs, the use of NSAIDs, genetic causes, cardiomyopathies, drug abuse, and arrhythmias. This has already been discussed, the type of heart failure according to left ventricular ejection fraction. Heart failure with reduced ejection fraction with an LV of less than 40%. Heart failure with improved ejection fraction with a previous LVEF of 40% with the follow-up measures more than 40%. Heart failure with mildly reduced ejection fraction where the LVF ranges from 41 to 49%, with evidence of spontaneous or provocable increased LV filling pressures, elevated natriuretic peptide, and non-invasive invasive hemodynamic measurements, and heart failure with preserved ejection fraction of regarding which Dr. Amina has discussed in detail regarding the various phenotypes, where the LV ejection fraction is more than 50%. Now, the symptoms of heart failure are basically of two types. One is a symptom of fluid accumulation or congestion. The other is symptoms of reduced cardiac output. The symptoms of fluid accumulation are dyspnea, orthopnea, edema, abdominal distance, and paroxysmal nocturnal dyspnea. Symptoms of reduced cardiac output are fatigue, weakness, and postural hypotension. If you look at the symptom assessment, even in patients with the stage B and C, we still use a NYHA functional class 1 to class 4, which is known to every one of us. The objective assessment of symptoms is by a 6-minute walk test, which is usually done in all cardiac rehabilitation centers to assess the number of steps the patient takes during a 6-minute walk test. This is also useful for following up patients on treatment with heart failure, whether the patient's treatment has made any improvement in his functional status. The clinical findings are cardiac enlargement, pulses alternance, gallop rhythm, raised jugular venous pressure, resting sinus tachycardia, and narrow pulse pressure, sweating, and peripheral vasoconstriction. Sweating and peripheral vasoconstriction, narrow pulse pressure are usually signs of reduced tissue perfusion. There's a Framingham diagnostic criteria for heart failure. The commonly used criteria requires the presence of 2 major criteria or 1 major and 2 minor criteria for the diagnosis of heart failure. It is highly sensitive, but a relative low specificity for the diagnosis of heart failure. The major criteria are patients with acute pulmonary edema, patients with cardiomegaly, hepatojugular reflux, neck vein distension, jugular venous distension, paroxysmal nocturnal dyspnea or orthopnea, pulmonary rales, a third heart sound, weight loss of more than 4.5 kilos in more than 5 days in response to treatment, central venous pressure greater than 16 centimeters of water, radiographic cardiomegaly. And the minor criteria are ankle edema, as Dr. Hari had said, it's a very, very non-specific finding in heart failure, dyspnea on exertion, hepatomegaly, nocturnal cough, pleural effusion, tachycardia with heart rate more than 120 per minute, and a decrease in vital capacity by 1/3 the maximal value recorded. The clinical diagnosis is based on history, physical examination, laboratory data, and imaging data. Now, most of us depend now on the laboratory data and imaging data, but the clinical gold standard in heart failure is increased pulmonary capillary wedge pressure at rest or exercise. The importance of clinical examination is that it can approximately assess the status of patients into 4 clinical groups, depending on congestion and inadequate perfusion. When there is congestion, there is the estimated pulmonary capillary wedge pressure is more than 22 millimeters of mercury. And when there is inadequate perfusion, the cardiac index is less than 2.1 liter per minute per meter square. So there are 4 groups. The warm, dry group, which you commonly see. Second is a warm, wet. That is patients with congestion. The same time, there is no evidence of peripheral perfusion loss. They are the patients who would benefit best with diuretics. Then we have the cold, dry group, where there is inadequate tissue perfusion, but no evidence of systemic congestion. And the 4th group, where there is cold and wet, where there is both evidence of systemic congestion as well as inadequate tissue perfusion. And this is the group where you have to treat with diuretics, inotropes, and vasodilators. And the group D would be the most symptomatic patients of all. This is again a pictorial demonstration. This is a Lynette Davis classification of these 4 groups, which I just said. Congestion at rest, low perfusion at rest. There is no congestion and no evidence of hypoperfusion. It is warm and dry. If there is congestion at rest, but there is no evidence of low perfusion, it is warm and wet. If there is No congestion, but there is evidence of tissue hypoperfusion, cool and dry. There is both hypoperfusion as well as congestion. It is cool and wet. The wet stages in heart failure, elevated filling pressures, raised jugulovenous pressure, hepatojugular reflex, orthopnea, bendopnea, and square wave response of BP, blood pressure during Valsalva. These are the clinical findings that helps us to identify patients with wet stage in heart failure. Whereas in volume depletion or hypoperfusion, the standard clinical findings are orthostatic hypotension, tachycardia, narrow pulse pressure, proportional pulse pressure, which is pulse pressure divided by the systolic pressure, and cold extremities. A large number of symptoms which I've already alluded to, like fatigue, shortness of breath, dyspnea, tachypnea, cough, diminished exercise capacity, orthopnea, paroxysmal nocturnal dyspnea, nocturia, weight gain or weight loss, edema, increased abdominal gurg and bloating, abdominal pain, particularly confined to the right upper quadrant due to hepatomic enlarged liver, loss of appetite or early satiety, chain strokes respiration, and somnolence. Now, if you look at the clinical presentation, symptoms and physical signs, the cardinal sign in heart failure is worsening dyspnea and fatigue. The most reliable sign that many people believe is paroxysmal nocturnal dyspnea, and an adverse prognosis is when the patient develops chain strokes or respiration. And a major prognostic indicator is unintended weight loss. Again, regarding physical findings, orthopnea plus JVP plus hepatojugular reflex is a very sensitive finding in physical examination, but presence of rales, JVP plus ascites is a more specific finding in heart failure. Orthopnea is a very, very important clinical finding in heart failure. The more important aspect of orthopnea is that it is associated with increased pulmonary capillary wedge pressure more than 28 millimeters to 32 millimeters. Studies, the ELEVATE study, which has demonstrated this particular factor, there is a positive association with jugular venous distension orthopnea. And in the absence of isolated right ventricular dysfunction, orthopnea and elevated jugular venous distension is associated with a pulmonary capillary wedge pressure of more than 30 millimeters of mercury. There is a score called orthodema score, which combines orthopnea as well as edema score. The score is more than 2. That indicates an increased orthodema score is associated with increased morbidity and mortality. One important clinical symptom which is rarely elicited is bendopnea. Bendopnea is dyspnea which occurs on bending forward at the rest at the waist. Patient sitting on a chair and bending to touch the feet with one's hands. Bendopnea is present if the dyspnea occurs within 30 seconds of bending. Bendopnea is common in heart failure clinics in cardiovascular rehabilitation centers and those with acute decompensated heart failure. The importance of bendopnea is that there is a prognostic utility. Patients with bendopnea has an increased 6-month mortality. There is an increased risk of death, heart failure admission, inotropic initiation, LVAD, or transplantation in patients who give you this history of bendopnea. Very often, this is not a symptom that we commonly ask for patients in heart failure. But one important thing to remember is that it is not a very, very sensitive symptom of heart failure. It may occur in other conditions like bronchopulmonary aspergillosis and obesity. And this is how you do the bendopnea evaluation. A patient sitting on a chair and asking to bend and touch his feet with the hands, and the dyspnea occurs within 30 seconds, he has got bendopnea. This second rarely done test probably, which is very important in heart failure, is the hepatojugular reflex. An increase in jugular venous pressure more than 3 centimeters, sustained on 10 seconds of continuous pressure on the abdomen with abrupt fall after pressure, is a normal response. If there is a sustained, if the rise in JVP is sustained for more than 10 seconds after the release of pressure, that indicates a positive hepatojugular reflex. Hepatojugular reflex indicates a pulmonary capillary wedge pressure in the more than 15 millimeters in the absence of isolated right ventricular systolic pressure. So a positive hepatojugular reflex is correlated with an increased pulmonary capillary wedge pressure. And another important point regarding hepatojugular reflex is that patients on persistent hepatojugular reflex after on treatment with versus people who had hepatojugular reflex resolved after treatment. The patients who had persistent hepatojugular reflex had a higher risk of 6-month mortality. Again, another common thing that we do is Valsalva's maneuver. The blood pressure response to Valsalva's maneuver allows estimation of pulmonary capillary wedge pressure. Normally, with the strain phase, the systemic blood pressure falls. Whereas in patients with heart failure, there is a square wave pattern. The blood pressure rises with strain and remains elevated throughout strain. And this response has been correlated with invasive pulmonary capillary wedge pressure. And the square wave response will not be present if there is isolated rise in RV and diastolic pressure. That is, if there's an RV dysfunction, this response is not very important, not very significant. The importance of this square wave response in Valsalva maneuver again is an association with the invasive pulmonary capillary wedge pressure. It gives you an idea regarding the pulmonary capillary wedge pressure. Now, coming to clinical assessment of hemodynamics in patients with heart failure. When you have a patient with symptomatic heart failure, assess for congestion and assess for low cardiac index. How do you assess for congestion? You look at the right heart findings and symptoms. The right heart findings are the elevated jugular venous pressure or JVD, bilateral leg edema, and presence of ascites. On the left side, hepatojugular reflex, orthopnea, bendopnea, and the Valsalva square wave has been shown to be associated with elevated pulmonary capillary wedge pressure, which is the hallmark, as I said, for presence of pulmonary congestion. To assess for low cardiac index or low perfusion, look at the extremities. If the extremities are cold and the pulse pressure is narrow, there is presence of low cardiac index. Even in the presence of warm extremities, if there is an inadequate response to diuresis, you can consider low cardiac index, even though the extremities are thought to be warm. This is an algorithm when a patient comes to you for clinical examination when they are symptomatic. 70 to 75% of patients with right-sided congestion will have elevated pulmonary capillary wedge pressure. And if the creatinine rises with diuresis and JVP is persistently elevated, again consider elevated right atrial pressure, pulmonary capillary wedge pressure ratio. The clinical assessment as per the ACC guidelines, recommendations for clinical assessment, history, and physical examination. In patients with patients with heart failure, vital signs and evidence of clinical congestion should be assessed at each encounter to guide overall management, including adjustment of diuretics and other medications. This is a class 1 indication. In patients with symptomatic heart failure, clinical factors indicating the presence of advanced heart failure should be sought via the history and physical examination. In patients with cardiomyopathy, a 3-generation family history should be obtained or updated when assessing the cause of cardiomyopathy to identify possible inherited states. A patient presenting with heart failure, a thorough history and physical examination should direct diagnostic strategies to uncover specific causes that may warrant disease-specific management. For example, tachycardiomyopathy requiring treatment of tachyarrhythmias. In patients presenting with heart failure, a thorough history and physical examination should be obtained and performed to identify cardiac and non-cardiac disorders, lifestyle and behavioral factors, and social determinants of health that might cause or accelerate the development or progression of heart failure. So this is the flowchart for evaluation of heart failure, possible heart failure, history and physical examination, acute onset, ECG, chest radiograph, routine labs, natriuretic peptide, they're negative. There is a lower suspicion of heart failure and heart failure is unlikely. If it is non-acute onset, ECG, possible chest X-ray, routine labs, and natriuretic peptides. Again, if they are negative, lower the suspicion of heart failure. Heart failure is unlikely. This investigation, clinical findings and investigation show a higher suspicion of heart failure. Imaging, if it is abnormal, heart failure is likely. This is the flow chart for evaluation of heart failure. In summary, history and physical examination are fundamental in the initial assessment and management of patients with heart failure. Depending on the clinical findings, patients can be identified as belonging to the 4 groups of the Lynette-Stevenson groups. History and signs like orthopnea, bendopnea, Valsalva maneuver, hepatojugular reflex, and add additional information regarding management and prognosis of patients with heart failure. Signs of low perfusion status are less sensitive compared to signs of congestion. Imaging and biochemical parameters are complementary, but do not supplant a meticulous history and thorough physical examination. Thank you for a patient listening.
Thank you, Venu sir, for that great presentation. So, I think clinical evaluation is the most important step. I think we may get close to the diagnosis of the etiology and all, especially when you do a thorough clinical examination and a good history. So I think history and physical examination still has a major role. It will be complemented by the investigation. So that is the basic thing which you have to carry. I think many clues we will get by doing the physical examination. So
And history. History is
and
also
history.
important.
Yeah, that's
The important point is in centers where there are, especially in peripheral centers where there are no facilities for advanced imaging and biomarkers. These are points which certainly help us to diagnose more and more patients with heart failure. I think it's extremely important for us to focus on that.
Abraham, any comments?
Well, like you're absolutely right, because even we have to have the clinical suspicion, and that comes from history and physical examination. Because if you do not doubt it, then we will not even investigate for it. And huge number of heart failures, or even especially HFpEF, is
Yes.
being misdiagnosed as asthma, psychiatric problems, etc., etc. And there was some study which from India showed that about 46% of the people who come to a diabetic clinic fulfill the criteria for HFpEF. And HFpEF also, the mortality is high. So we should keep our eyes and ears open. And Venu sir gave a wonderful talk about how to keep the eyes and ears open.
Thank you. And there are some questions on the post-test. Post-test is at the end of the course. That is on the last day, there will be a post-test. So the post-test, you do the post-test to get a percentage of marks, and then automatically the certificate will be generated. That is a plan. So all the many questions the people are asking, criteria or FF and all, already that there are sessions discussing that. And many of the questions we will answer in the next session, which are relevant in that particular session. So thank you, everyone. And it's already 9 o'clock. So
Thank you, Hari and Umar. I enjoyed the sessions. Great talks earlier.
please post your comments and questions how to improve the program. So we are planning to do 2 sessions per year for the physicians. So it is not for everybody will benefit when the trainees and the physicians, the cardiologists who are attending benefits this. So thank you, everyone. So and good night. Next program is on 9th Wednesday, again 7 p.m. to 9 p.m. The teaching materials are there in the drive, which is given. The address is given in the WhatsApp group. So you can post any comments in the WhatsApp group, or you can post it here. We will collect the questions and give the possible answers in that recap session on 9th. The session starts with a recap where all these questions will be answered. Okay. Thank you so much and good night.
Good night.
Yes, you can access all webinars later on. It will be posted. That the sessions recordings will be posted. You will be able to see. So thank you.
Good night.
Good night, sir.
Good night.